Vanakkam. Who says you cannot learn while having fun? Welcome to the Great TANPAPS Quiz, the infotainment program in the run-up to the annual conference of the Tamil Nadu and Pondicherry Association of Plastic Surgeons to be held from February 9 to 11, 2024. Question number 1. 4 clinical stages of quiescence, expansion, destruction and decompensation are seen in arteriovenous malformations, venous malformations, capillary malformations or lymphatic malformations. The correct answer is arteriovenous malformations. The staging system in arteriovenous malformations is the Schobinger classification, where in stage 1 it is the stage of quiescence with or without a vascular skin stain. The AV malformation is present but there are no clinical symptoms. In stage 2 there is expansion. So it is a stage 1 plus enlargement. Pulsations can be seen. There will be a palpable thrill and an audible bruit. In stage 3, there is destruction. It is stage 2 plus dystrophic skin changes and skin ulceration may occur here. In stage 4, there is decompensation. That is stage 3 plus congestive cardiac failure with increased cardiac output. Question number 2. The following is an example of ablative laser treatment. Erbium YAG laser with a wavelength of 2940 nanometers, Neodymium YAG 1320 nanometer pulsed laser, IPL intense pulse light or LED light emitting diode. The correct answer is erbium YAG laser with a wavelength of 2940 nanometers. Lasers can broadly be broken into two categories, ablative and non-ablative. Ablative lasers give out an intense burst of energy which is delivered onto the skin. The water in the skin is heated and water and tissues vaporize or coagulate. As a consequence, new layers of collagen are produced. These type of ablative lasers are ideal for skin rejuvenation, severe facial wrinkles, dyspigmentation and textural skin challenges on thicker skin. Non-ablative lasers are the Neodymium YAG 1320 nanometer pulse laser, the intense pulse light, LHE or the light heat energy, LED or the light emitting diode. Non-ablative lasers are safer but require epidermal cooling. Only modest cosmetic enhancement can be achieved. Question number 3. The following is true about the jejunal flap used for pharyngeal reconstruction. It is reversed to avoid isoperistaltic movement. Anastomosis of the jejunum must be done with the neck hyperextended. It is based on the second mesenteric vessel. Incision is made on the mesenteric border of the jejunum to spatulate it. The correct answer is the jejunal flap is based on the second mesenteric vessel. The jejunal flap requires isoperistaltic movement and this should be ensured so that there is no physiologic obstruction to the movement of food down the pharynx. The anastomosis of the jejunum both proximally and distally must be done with the neck in neutral position because the jejunum can expand. It is based usually on the second mesenteric vessel. Incision is made on the anti-mesenteric border of the jejunum to spatulate it. Question number 4. The most appropriate tendon transfer for combined high, median and ulnar nerve palsy is the use of FDS of the ring finger, abductor digiti minimi, palmaris longus or extensor indicis proprius. The correct answer is extensor indicis proprius. All these choices offered can be used for opponent's plasty. But in combined high, median and ulnar nerve palsy, FDS of the ring finger cannot be used because it is going to be paralyzed in high median nerve palsy. The abductor digiti minimi cannot be used because it is paralyzed in ulnar nerve palsy, and the palmaris longus again is paralyzed in high median nerve palsy and cannot be used. So the ideal transfer would be extensor indicis proprius or the Burkhalter procedure. Question number 5. The tic-tac-toe classification of mutilating hand injuries was described by Delitala, Wainswig, Fuchanvi or Rank and Wakefield. The correct answer is Wainswig. The tic-tac-toe classification describes 4 things: which aspect of the hand is involved, what component is involved, what is the vascularity status of the hand or finger, and what specific part of the hand is involved. The first is the type. It could be a dorsal mutilation, palmar mutilation, ulnar mutilation, radial mutilation, transverse mutilation, or a degloving injury or a combined injury. The components could be soft tissue loss, bony loss, or combined tissue loss. The vascular status could be 0 where the vascularity is intact or 1 where it is devascularized, and the specific part of the hand involved is described in the tic-tac-toe pattern. Let us see an example to understand this better. In this injury, it is a type 1 mutilation because it is involving the dorsum of the hand. It is a type A mutilation because it involves only the soft tissues. It is a type 0 mutilation because there is no vascular compromise, and the zones involved are 2, 3, 5, 6, 8 and 9. So this would be the complete diagnosis of this mutilating injury according to the tic-tac-toe classification. Question number 6. The structure shown in the nose is the Kieselbach's area, the Pitanguy's ligament, internal nasal valve, or the keystone area of the nose. The correct answer is Pitanguy's ligament. On the dorsal aspect of the tip of the nose, the alar domes are interconnected by superficial ligaments in the superficial fascia and by the interalar ligament proper, and this is known as the Pitanguy's ligament. This ligament stabilizes the lower lateral cartilages at the level of the medial middle crura junction. Disruption of this ligament can lead to widening and distortion of the nasal tip. At their most superior extent, the upper lateral cartilages are overlapped by nasal bones for about 4 to 5 millimeters. This is known as the keystone area. It is the widest part of the nasal dorsum. The mucosa over the perichondrium of the septum is highly vascularized and receives blood supply from ethmoidal, sphenopalatine and labial arteries. There is a dense area of vascularity in the anterior septum, and this is known as the Kieselbach's area. The internal nasal valve is the narrowest area of the nose where turbulence of inspiratory and expiratory current takes place. It is seen at the region of the caudal border of the upper lateral cartilage and anterior end of the inferior turbinate. Question number 7. When doing a tarsal tunnel release, what is the structure shown? The calcaneal branch of the medial plantar nerve, or calcaneal branch of the lateral plantar nerve, or medial plantar nerve, or lateral plantar nerve. The correct answer is medial plantar nerve. When doing a tarsal tunnel release, there are actually 4 medial ankle tunnels to be decompressed: the tarsal tunnel, the medial plantar tunnel, the lateral plantar tunnel, and the calcaneal tunnel. The tarsal tunnel proper is released by dividing the flexor retinaculum, the distal end of which is the origin of the abductor hallucis brevis muscle. The medial plantar tunnel is deep to the abductor hallucis brevis, and by retracting this, the medial plantar vessels are released. Similarly, the lateral plantar vessels are released and the calcaneal branches are also released. Question number 8. The variation of the tram flap shown is MS0, MS1, MS2 or MS3. The correct answer is MS2 or muscle sparing type 2. Though the name of the flap is tram flap, transverse rectus abdominis muscle flap, varying amounts of the muscle are included in the flap. In the MS0 or the muscle sparing 0 flap, the rectus muscle is completely transected. In the MS1 flap, it spares the lateral band of the muscle to preserve the innervation of the muscle. In the MS2 flap, only a small central portion of the rectus muscle around the perforators is transected, so both the medial and lateral borders of the muscle are spared. In the MS3 pattern of the flap, no muscle is harvested along with the flap and only the perforator supplying the flap is harvested. This is otherwise known as the DIEP flap or the deep inferior epigastric artery perforator flap. Question number 9. Mullerian inhibiting factor is produced by male germ cells, oocytes, Leydig cells or Sertoli cells. The correct answer is Sertoli cells. Gonadal sex or the differentiated stage begins at the 7th week of intrauterine life. Two factors that play a role in this differentiation are the Mullerian inhibiting factor produced by the Sertoli cells in and around the seminiferous tubules, which cause regression of the Mullerian duct system at about 9 to 11 weeks, and the hormone produced by the Leydig cells, which is analogous to testosterone. Question number 10. The permanent skin substitutes, the autogenous keratinocytes contain epidermis only, epidermis and dermis, or biosynthetic dermis. The correct answer is autogenous keratinocytes contain epidermis only. Permanent skin substitutes are of various types. Appligraph is composite allogenic tissue and contains both epidermis and dermis. It has two layers, a collagen matrix seeded with human neonatal keratinocytes and fibroblasts. Orcell is also composite allogenic tissue containing both epidermis and dermis, but this is collagen sponge seeded with human neonatal keratinocytes and fibroblasts. Epicell consists of autogenous keratinocytes and contains epidermis only. This has a single layer of cultured autologous keratinocytes. Alloderm consists of allogenic dermis, so it contains only dermis. It is a processed allograft consisting only of acellular dermis. Integra is partly synthetic tissue. It has a silicone outer layer and a layer of bovine collagen glycosaminoglycans and shark chondroitin sulfate dermal matrix.
I hope you liked the video. I enjoyed making it. Please register for the TANPAPS 2024 conference, a wonderful scientific and academic feast where many innovative and interesting sessions are being planned. Do visit the website to see the details and to register. Vanakkam.